what they found is that with platelets, they're a very good source of what they call growth factors, and there's a list of all these factors that are found involving platelets. And what's happened is with platelets, they've found that when you have these growth factors can go to an area of inflammation and damage, and they can allow the cells to begin to heal themselves. And when they're talking about signaling mesenchymal cells, that's basically like a mesenchymal cell is basically a stem cell or an early cell that's not differentiated that well, and it can go ahead and start healing in that area. By going to an area of a tendon or a suspensory ligament where there's some damage there, they will concentrate those platelets and inject them into the injury. And by the fact that there's already an injury there, those platelets will adhere to the area and they'll degranulate, and you'll release all these growth factors. And the growth factors will then go ahead and trigger the cells in that area to try and heal that particular injury and hopefully heal it in a more normal fashion with less scar tissue. The problem that we have at the racetrack or in any sporting event is when you have a tendon injury or a ligament injury, there's a large percentage of recurrence. And the reason being is the scar that's formed does not allow, it has no stretchability to it, no elasticity to it. Normal tendon tissue and ligament tissue has the ability to stretch and go back. Whereas when you have scar tissue forming, the scar tissue does not have any elasticity. And so what you do is you'll get a horse that's, where you think it's healed, it'll look fairly good on ultrasound, and you get the horse about ready to run. Next thing you know, the thing tears the scar tissue that you have, and you're back to square one. So what the idea with this therapy, as well as the stem cells, is you're trying to minimize the scar tissue. You're trying to get as much of the tendon and suspensory ligament or ligamentous tissue back in as normal a state as possible and give you that stretchability that you've lost, that you will lose if you just have scar tissue. At the racetrack, as owners, I'm sure that you've gotten your call from your trainer and they'll say, well, we've got it's sooner or later you're going to get it if you haven't yet. You know, we've got an ankle that's a little filled. You know, we're going to try and work on it and see how it goes. Well, the typical treatment therapies in the past have been going from ultra conservative to more aggressive. You know, you would start by, say, icing the affected joint, putting the horse on a couple tabs of bute, some non-steroidals, which include bute, banamine, and now there's a new product out that it's a COX-2 inhibitor called Equiox, which is better for the horse's liver, but it's basically a non-steroidal. The other thing I'm sure you guys have gotten bills for at times are for shots of Legend or Adequan, and those are more systemic articular therapies to help decrease the inflammation when a joint blows up or whatever. And then as things will progress, your trainer or your vet may recommend that the horse be injected intra-articularly with either hyaluronic acid or corticosteroids or a combination of both. And corticosteroids have been around for a long time. There's a big controversy right now throughout the nation on any kind of steroids, anabolics, or even anabolic steroids, obviously, but now corticosteroids are sort of coming under fire as far as their use in the racing industry. Initially, certain corticosteroids at high doses have been shown to be really deleterious to the joint. You know, they wear out the cartilage, they cause fibrillation of the cartilage, thinning of it, and while they get some immediate response and the joints are quiet and they do good, it's sort of a double-edged sword. If a horse might have a chip in there along with it, you know, the horse can go ahead and train, but you're still creating more damage with that chip in there, and the horse won't really show it. some of the research that has come up in the recent years that was done like at Colorado State with Dr. McElraith, and that with certain corticosteroids, so at low doses, they've found that it's actually been protective to the joint. So used properly, corticosteroids can be beneficial to a horse, but you have to use proper dose and the proper caseload. There is much discussion now as far as they're talking about banning corticosteroids in thoroughbreds, or what they want to do is have like a seven-day withdrawal period on corticosteroids. And so I think that there's still going to be a lot of controversy over them. And what that has done is it's caused us to search for other ways of treating joint disease. And the newest one that's come out up to this point has been the IRAP. And just briefly, when there's inflammation in a joint, there's a lot of nasty bugs or factors that are released into the joint. You get a hot joint that's full of what they call cytokines. And interleukin-1 is the most prominent one that you see in joints. It's what they call a pro-inflammatory cytokine. It's a major mediator of joint disease, and it's produced by synovicytes, which is the lining of the joint, chondrocytes, which are the cartilage cells, and also when there's inflammation, you'll get red cells and white cells released in the joint, and it can be released by white cells as well. And what that does is it stimulates these neutral proteases in the joint, and those are responsible for a lot more tissue inflammation and destruction. The problem is if you have an injury in a joint, it releases all these bad factors in the joint, which in turn create more inflammation, and it's just a really bad vicious cycle. So the theory behind the IRAP is there's an antagonist protein that's actually naturally produced in the joint, and it's produced by the same cells that produce the interleukin. But when there's injury, you want to have a balance, an equal balance between the two of them. And when there's an injury, you tend to get more interleukin-1 produced and less of the antagonist protein. So the thought was to try and find a way to get that back in balance. How can we get some more of the antagonist protein in there to counteract it? And what happens is anytime you have a cytokine, they work on cells. They're like a local hormone, but they have to have a receptor on the affected cell to work. So what happens is with IRAP, you try and get the antagonist protein to go ahead and bind to the receptor. You have the interleukin as the red, and you have the IRAP as the blue. What you're doing is you're trying to neutralize the interleukin by causing the IRAP, increasing the levels of the IRAP to bind to those receptors so the interleukin cannot get in there and exert its effect.